So I think we're going to get started. Hey, you guys, thanks for coming. On behalf of Captain Scott Goldstein, welcome to the Pikesville Fire Department in their training space. For those I haven't met, my name is Sean Aubert-Utz. I'm anesthesia and adult ICU critical care at Hopkins. I'm a member here at Pikesville, and I have the honor of serving in the medical director's office as CAR 609. On behalf of the medical director's office and Dr. Pollak, we thank you for what you do, as well as for your dedication to lifelong learning. And that's what this EMS training series is put forward to help satisfy that hunger that you all have for lifelong learning. So today we have Dr. Pollak. He's joined by Director Schenning and Acting Chief Aubert-Utz to talk about the state of the Baltimore County Fire Department EMS system. Dr. Pollak is a professor and chair of Department of Orthopaedics at the University of Maryland Medical School. In addition to academic and clinical practice, Dr. Pollak has a long-standing interest in EMS that began while he was a volunteer firefighter and EMT before college. He currently serves as the medical director for Baltimore County Fire Department, Special Duty US Marshal, and is the medical director of the University of Maryland Shock Trauma Center's GO team, amongst many other leadership roles. Dr. Pollak, thank you for being here. Thank you for all that you do for mentorship for me and for the rest of us, and thanks for being here. Thanks. And we're going to hand off to Director Acting Chief Aubert-Utz. Thank you so much.
No, thank you. I was a director once, so you weren't totally wrong. So good evening and welcome to Pikesville Volunteer Fire Station. Thank you, Dr. Aubert-Utz, for putting together this EMS education series. I don't know what that is. Is that you or is that us? That dinging. It's driving me crazy already. So I'm super excited to be here tonight and in the company of Dr. Pollak and Director Schenning. These two gentlemen work so much, so hard behind the scenes to guide and mentor and create a phenomenal EMS system here in Baltimore County. A little bit about where we're going. Next week, the chief officers have a full staff meeting off-site, which we do at least once a year. I'm pretty pumped about this because we're going to spend the day talking about organizational change and strategic planning. We have a professor from Johns Hopkins who's a good friend of mine, Dr. Joan D. Simone, coming in. She's going to give us a lecture and some ground school on how to navigate organizational change and how to move an agency forward. So I'm super excited to have Dr. D. Simone come in and talk to the entire command staff. And the rest of that day, we're going to be surrounded by whiteboards, and we're going to be jotting down all of our thoughts about where we are, where our issues are, and where we want to be in the future. And from that, we're going to create a 5-year strategic plan, which is going to involve a lot of discussion about EMS. EMS is 80% of what we do. We say that over and over and over again, and we should be profoundly proud of the fact that we do it, and we do it well in Baltimore County. I want to be the best of the best agency in the nation. I want to be the model that everybody looks to, that wants to emulate. We certainly have the talent and the depth in this organization to do that, and together, that's where we're going to be in the future of this organization. My glass is half full. If you know me, I'm super pumped. I can't wait for next week, for the 28th. I can't wait to develop this plan, and that plan is going to provide a product for you that arguably you haven't seen in at least 2 decades, and that's a vision for this fire service. It's a vision for this fire department of where we're going and how each and every one of you contribute to the success of this organization. Chief Hughes asked me a lot of questions. He's like everybody's kid brother. And I think he's like 6 months younger than me or something maybe, so he's like my kid brother. But he asked some really valid questions. And the one question he asked me routinely is, how do we measure success? How do we measure success? You can't measure success unless you have a benchmark to apply that against. And that's what we're going to do in the next 5 years of this organization moving forward, is have a plan, to have a vision. We're going to have a benchmark to measure our success. I'm a risk taker. I'm not afraid to fail. We're going to take some risks. We're not going to hurt anybody, right? That's not what I mean by taking risks. But we're going to try some stuff that we may not have tried before. We're going to put this think tank together. We're going to create innovative ideas, and we're going to move this organization to be the gold standard in the nation. I know I can say that because I know I have the workforce to do it. Whether you serve as a volunteer, a career, or you wear two hats, we have a talented, great depth workforce of people. We have great guidance and leadership from Dr. Pollak and all the deputy medical directors and the associates. We have what it takes to be the best of the best in this nation. I'm not going to bore you with me. Director Schenning has a lot of facts for you. Dr. Pollak has a lot of insight for you tonight. But I'll leave you with this. We have to have providers, whether it's basic life support or advanced life support, that are making good clinical decisions, who understand differential diagnosis, who advocate for our citizens, and do the right thing even when nobody's watching, right? We have got to take care of our communities and take care of our citizens and be certain that we are advocates 24/7, and be certain that we're making the right decisions for the right people all the time, for the most people all the time. We got it in this, folks, and this room is full of future leaders, current leaders, who can take us to the next level. So enjoy your evening. Enjoy Director Schenning's presentation. Dr. Pollak, thank you so much for being here. Thank you so much for supporting this agency for so many years. It is an honor and pleasure to work with you.
I'm only 6 months older, so it's not so many.
Okay. You're only 6 months old?
Older than you.
Older than me?
Yeah.
Really? You checked my birth date?
And I'm 6 months older.
Oh, okay. I thought you checked my birth date on the way in. I'm like, what is going on here? This guy's smarter than I thought he was. So anyway, thanks for being here. I'm here for questions, as Rich and Dr. Pollak. Enjoy your evening and what they have for you. So thanks.
Thank you. Thanks. Thank you, Chief. Welcome, everybody. Thanks for coming out tonight. Just the fact that we have such a packed room on the weather, given the weather that we're having tonight, says a lot for, our commitment to EMS. Dr. Aubert-Utz, this entire lecture series that he has been putting on is absolutely fantastic. So please, if you haven't met Dr. Aubert-Utz, because there's a lot of new faces here tonight, please stop by, thank him. This started off as something we wanted to do down the academy many years ago when I was down there, and the whole concept of continuing education, it's kind of like the movie. I always said, if you build it, they will come. And we've always said, if we were to offer very good, high quality training and education, it was very hard with the resources that we had to be able to commit to that all the time. Dr. Aubert-Utz came on, and I've spelled his name. I don't believe anybody came up and said, Dr. Aubert-Utz, will you put this series together? This is what we need. Normally, it's somebody has some passion inside of them, and they just, they feel like they need to move that forward. There's some people have called from other jurisdictions, Cecil County, Anne Arundel County, Howard County, asking if they can start participating in it. And when you get this kind of quality education, these quality speakers, and it raises the professionalism of EMS, people will come. So thank you very, very much. This is a long time overdue, and you're certainly setting the standard very high. So thanks again. Tonight I just wanted to go over a couple things, and Chief talked about that. In case you can't tell, I'm very excited, looking at the future of EMS. EMS has been my passion for a lot of years. Been doing it for about 33 years between career and volunteer. But I got to be honest, the whole time I've been in the fire department, nobody's came up and kind of said, hey, we're working on a blank slate. Where do you want EMS to be? Normally it was, hey, now you're running EMS, and we kind of did things that we did. Now, strategic planning, I was like, I didn't think in a political organization you had strategic plans, because you never knew who was going to be there in 2 or 4 years. So it was very rare that people actually set them up. But to hear where we're going to be going in the future, this is very exciting. I don't know if Chief Utz wants to let you know, but she came in the office the other day. I was so excited. I pulled out a clipboard and I said, here's 4 pages of things we'd like to do. And she looked right at them. So I'm giddy with excitement with where I think we're going to go. And just looking at the amount of work that's involved, my wife doesn't like that very much, because it's going to be a tremendous amount of work. And nobody can do all this alone. So when you start talking about teamwork, in the fire service, nothing can be more true than the team that it's going to take to get to where we want to get in EMS, and then on the fire side as well. So, and I look forward to working with everybody as we do that. Tonight I do want to talk a little bit about some of the things about our system a little bit of its history. Some of the lieutenants have heard this before. Nice. I'll let that go down for the people on the phone.
4601 Kelman Road, Scottsville Road, and Bering Old Road, West 1970.
So there's always been a saying out there, if you've seen one EMS system, well, you've seen one EMS system. Because really, every single system that you go around, if anybody's been to National Fire Academy, been to any of the national conferences, every system that you go about's got some little tweak that makes it a little bit different. What might work in one system may not work here. You know, there's many times people look around some of our surrounding jurisdictions, they'll like look in the paper and they'll see their budget. And they're like, how can their budget be 5 times more than what ours is? But theirs includes capital expenses like fire academies and buildings and equipment, and ours may not include all that. So, you know, always comparing apples to apples, oranges to oranges, you know, is a good place to start. But, you know, we're unique in very many ways in Baltimore County. You know, and in a minute I'll just touch about some of them, but we have some very unique challenges that we don't have with them. One of the things, I don't know if anybody's noticed, if you've ridden the Medic in the last 2 to 3 weeks, it's been incredibly busy. I mean, so would it surprise anybody if I told you our call volume is actually down, but our hospital times are way up? So our call volume isn't actually as busy as what it's been, but it's way up. And part of that is because of some of the borders that are happening in hospitals. So, you know, that's one of our big challenges that we have. We have other jurisdictions that can come into our jurisdiction and put us on reroute. So that can back our system up while it frees up some of the other jurisdictions and things. So we have a lot of different things that we face and a lot of challenges are going to. I already talked about exciting times. It takes a team approach. One of the things, you know, that a fire chief does is, you know, tries to get us the resources we can do so we can move ahead. You know, so just a lot of people haven't seen the whole thing, but, you know, for those of you that know, we have 4 EMS shift commanders, A, B, C, and D shift. And now we have one, if anybody's dealt with him up the office, EMS Captain Jeff Willits. Danielle Natz down at the Fire Academy is that. And then everybody knows about the way our system works with the district officers. We were recently able to bring Lieutenant Bill Ulrich down to the Academy. So we stole him from the field for a while. He's doing a lot of good projects down the Academy. And most recently, we advertised as a part of one of the suggestions that B Shift brought up at our EMS Lieutenant Summit that we should have another lieutenant at the EMS office, and we were able to advertise for that. Lieutenant Stewart's going to be starting up there on April 1st. So I think if you look at that, I think that's a who's list of EMS providers moving forward, and I think we're starting to assemble a really good team to face some of the challenges that we're doing. Maybe not everybody knows this, but we do have a lot of physicians that are involved in our program. Dr. Pollak, everybody's met, and he'll talk in just a little bit. We have 2 deputy medical directors, and we were able to elevate Dr. Vipberg as a deputy medical director, along with Dr. Bernius. And Dr. Jenny Geither, Dr. Sean Barinholtz, Dr. Jeff Sagal as associate medical directors. So a lot of people don't know that, but we actually meet at least every other month to every quarter, and we talk about a lot of these things where we want to go in EMS. Myself, Dr. Pollak, we talk every Tuesday morning, just at least once a week, if not many more times during the week. So there's a lot of things that go on behind the scenes. You are going to see some changes at the EMS office now that we're getting another lieutenant up there. The EMS ones know on day works, they're pretty much assigned up to the headquarters, up at headquarters on there. And part of that is I want to be more responsive in EMS to when you guys bring problems forward. Many of the lieutenants know we're starting to do the conference calls that we'll be doing, so we start passing this information on so it gets down to everybody. But what I do is I tell you, if you have any problems when you're out in the field, you're starting to see things at hospitals. Prime example just happened. Where's Lieutenant Schuler? She's in here. She had 2 cases here very recently with a drug that was circulating around. She brought that up. We were able to notify poison control, consult with other hospitals. I want that information to continue to flow up to us so that if it is something that we need to react on, or even if it's an issue that we can address, I don't want something to go 2-3 weeks without getting addressed. If we're aware of it, many times we can fix things that exact same day. whether it be a technology piece, whether it be something going on with a hospital. So my goal is really for us to be more responsive to you guys as an EMS office. So please, if you have issues and things like that, we're talking to the district officers daily. I talk to the EMS ones at least every other day, at least our first or second day in. And they're also up at the office. So we have two extra people up there to help us with a lot of these projects and stuff. In addition to many physicians that we have that we can call, if it's something clinical or something we need an answer for. So, I think we built a really good team so that we can move forward. So, just talking about a couple things with some of our challenges, and I always describe us as, is that my water? So I always describe myself when I'm around, when people ask about Baltimore County system, and you got to put this into perspective, but, ooh, my mistake. We're a high volume, okay, fire-based combination system, and we have a very large geographic area, more than most of the jurisdictions that surround us, and we're publicly funded. You change any one of those unique attributes right there, you've changed the way we can steer the ship. And would everybody agree? If, when something comes out, I have to consider, A, can we afford it? B, will it work in our system? What works in one system where they're dealing with one hospital is much different than working in a system where you're dealing with 10 or 15 hospitals. Something that all volunteer stations, and then there are stations out there that, we have a lot of two-hatters that do both. We are an approved operational program through MIMS. Okay, so we have some mandates that we have to meet with that. They're pretty easy for us to meet. And we're part of the larger county fire department and part of Baltimore County. And in a little bit, as we start talking about kind of where we may go with some of these things, being a part of a large county gives us a lot of resources. And we're going to start talking about a lot of that kind of stuff as we start looking into the term mobile integrated health and stuff. If anybody hasn't had the opportunity, and I'll bring it up with Dr. Aubert-Utz, is to bring out some of the peer recovery specialists. So one of the things now with the opioid crisis that's going on, there's several different ways to manage that. There's the Narcan Leave Behind program that the state came up. We kind of said, being Baltimore County, they have these tremendous resources, and every morning the EMS shift commanders that come up to headquarters, they're scanning, and we run reports for opioid overdoses, and we refer them directly to the health department. They dispatch somebody from the health department that goes out to the scene if we get it early enough, and we can bring them right out to the scene, or they're going out the next day and canvassing the area where that happened. And their motto there is they give a shot of hope. So they'll come out, they'll talk, and they'll try to get these people into a treatment program. We have several success stories. One area that I think we're really weak in, and that's something that I'm striving to improve on, is to be able to share success stories back with you. I know of them because I hear them all the time, but we need a better mechanism to be able to get those out to everybody. So that's on us, and that's something that we're going to work towards. But just to tell you how busy we have been and how busy we are, and most of these are a typical month, okay? On average, we run about 11,500 incidents per month. Okay, we transport there, 64% is a typical month, about 7,500 transports to the hospital per month. Okay, our supervisors are upgrading anywhere between 90 and 125 times per month. We get about 240, 260 refusals. And out of all, you take all those things, and somebody here with a calculator or a phone can do the math, but we only get about 15 to 20 customer service complaints that come into the EMS office with that. So that tells me people just don't complain that much. You do that, that's less than 1%. So, and that is a fantastic stat for somebody like me who's overseeing a division, that I can say less than 0.01% of the time to any of our calls. If we were making widgets, that would be a great factory to work in, but we're not. We're dealing with human beings, which is much harder to do, and be able to carry on good customer service in very difficult environments sometimes, to know that we only get that many complaints. So that's a kudos to the professionalism of the crews that are out there. Just a couple things that I'm starting to notice. We're looking at some our calls, I actually pulled it since we started running eMeds Elite. So, but the one trend that I did note with that is you see the red mark is starting to look at our call volume. We're starting a little bit earlier now. So it used to be we didn't get really busy till about 10 o'clock. All right, that's starting to back up and we're starting to see the volume increase earlier in the day, and it's also starting to stay a little later during the day. So now it's actually going to about midnight as opposed to what before it would stop around 11 o'clock. So something that we're keeping an eye on. You guys already know that. We're looking at calls by day of the week. Obviously, our weekends, they may not always seem it because we're down some units that go out of service during the weekend, but we have the ability to bring them up when it does get really busy. But majority of our calls are coming in through the weeks. Fridays tend to be the busiest days. That surprised me. I actually thought it was going to be a Monday. Anybody? I see a lot of people nod, and I agree. And then as we start looking forward to the future, one of the great things about eMeds is that we can use data to drive decisions. That's something we haven't really done for a long time. And now we have that ability. We're starting to touch our toes into this stuff and make some good decisions, I think. But something we're going to have to keep in mind, 44% now of the patients that we take to the hospital are between the ages of 50 and 89. So we do have an aging population within the county, hitting be more on Medicare. So that's probably going to affect our call volume going forward. So we'll start looking and projecting that out, and we'll be making some decisions on some things that we can do to address that. Yeah. What's that? To be honest, that was before I pulled with eMeds Elite. So I would actually have to go into the old system and pull it. But I haven't specifically. Yep.
The question was how much were those manufactured in Charlestown?
So, ironically, 6 incident types in particular make up just about 66% or 67% of the calls that we get. So, sick persons, falls, breathing problems, traffic, transportation accidents, chest pain, and unconscious. That does really take up the majority of the calls that we're running. And I just looked at February for these numbers. Cardiac arrests, we had 143. Out of those, we treated and transported 55 of those dead on scene without intervention or with interventions that we worked, and then we pronounced with our protocol. It was about 30, and then without interventions that we just pronounced were 58. We used CPAP 84 times, 78 times that improved. 5 there was documented no change, and then 1 time the condition worsened and they were required to be intubated. Last month we gave out 140, we had 200 doses given on 140 incidents of all those. Like I said, now we're starting to refer them to the peer recovery specialists and to the health department, and we're also reporting them into a state system for the opioid command center for the state. We had 10 STEMI alerts. I think all but 1 was a confirmed STEMI at the hospital when they did that. So that's a little bit what I have. I'm going to hand it over to Dr. Paula Keys and talk a little bit about some of the stuff we were doing with cardiac arrest and give you some of his words. There you go. And then just flip. Yep.
All right. So before we start, I just want to add thanks to Sean Aubert-Utz for putting this series together. This is fantastic. I'm sorry this is the first night I've been out to this live, but I've heard nothing but great things about it. I've seen a bunch of the stuff that's accumulated, and we're grateful for putting this together. I want to apologize in advance. I always tell people never apologize for your slides, but I was sitting here going through these. I apologize for the organization of it, but I think the material still come across well. I want to talk about some things that we're doing well. I want to talk about some things where we have an opportunity to do better. I want to talk about some interesting topics that have kind of come across my desk in the past weeks, months, and in some cases years. and then I want to leave room for questions. But I want this to be sort of an open forum. If people have questions, don't hesitate to stop. So I was about to do that during Rich's presentation. I just wanted to clarify that over 50 is not the older population, okay?
Full disclosure, I turned 50 this year, religion.
It's season. It's season.
No, it's still pediatric, okay?
That hard, yeah.
All right, so I want to start with a couple slides talking about what we do well, because I'm kind of proud of these slides. We've been talking for a long time about high performance CPR, about crew resource management, about how we can do better on cardiac arrest calls, and I think everybody in this department works to do the best that we can do on those calls, because we know that that's where the rubber really meets the road for what we do. And we do a lot of different things. But when you measure the effectiveness of EMS systems nationally, this is one of the areas where we have the best ability to benchmark ourselves against other people. So OHCPR means out of hospital CPR. CARES data is cardiac arrest registry to enhance survival, and it's a national registry that allows us to put together all of our information and use what's called Utz criteria to help define how well we're doing. And this is a chart that I put together from a much larger chart, but you see at the top left, performance measure. Utz survival means witnessed by a bystander, witnessed cardiac arrest by a bystander, a patient who presents with a shockable rhythm. And the bottom one, Utz bystander survival category, means the same as the above, witnessed arrest, shockable rhythm, plus some bystander intervention. The bystander did some CPR, the bystander did used an AED, some bystander intervention, or it occurred with one of us. It was witnessed with one of us there where there was an immediate intervention. So our survival rate in those two categories for out-of-hospital cardiac arrest is pretty shockingly high, quite frankly. That's absolutely outstanding. The Maryland numbers, not even close to that overall. So when people talk to you about some other great systems around the state, you should be proud that because of the work that you do every day, we're the target to hit for how to perform in the state. And we do it in a jurisdiction that is massive, that has geographic challenges, that has, we've got medic units responding from Randallstown to Cockeysville for a cardiac arrest because of wait times in emergency departments. So despite all those challenges and all those things that they feed us every day, that's what you're able to do. And in the United States, you see the numbers are pretty typical for the rest of Maryland. So we should be proud of that, but it doesn't mean we don't have a lot more that we can do to get even better, because there's almost 55% plus of the population that's not surviving. We know that we don't do perfect every time, but we try our best. This is more of the Utz information with regard to situations where CPR was attempted. When you break it down to witnessed arrests with bystanders, there's 323 in the calendar year 2018. And of those, when you look at the initial rhythm, VFib, VTAC, something shockable, 56 patients, 33 of them wound up admitted to the hospital, 25 discharged alive. And if you look at that bottom box where it says neurologic status, the CPC 1 or 2, those are the two neurologic categories where it means people walked out of the hospital with pretty good neurologic function afterwards. That's 20 out of an initial 56 that were presented to us. Those are great numbers. And it talks about the importance of what you can do out in the field. And it's not about the drugs that we push. It's not about the fancy stuff we do. It's about how well you do the real basic stuff. CPR, AED. Right? It's the real basic stuff, and how we do it as a team and a function that gives the patients the best chance for survival. This is the Utz survival report for unwitnessed arrest, and you can see the numbers are much less in the unwitnessed situation, very few survivors. And this is witnessed by a 911 responder, obviously a smaller number overall, 23 patients, 9 admitted to the hospital where the initial rhythm is VFib, VTAC. If the initial rhythm is asystole or something else, the numbers are worse, but 7 out of 9 who are admitted wound up with a discharge with an intact neurologic function. So this is very positive data overall. How do we get that? How do we get, what are we doing that's given us data that looks that good? And I think that there are lots of things that we do every day that contribute to the overall approach, but it's about our professionalism. It's about how we approach every call, how we approach every patient. And I can tell you that in 20 years, for the most part, I get the distinct privilege of getting to review the worst of the worst, when we don't hit that mark. And I can tell you that at the times when we don't hit that mark, it's not because we have people who are dumb. It's not because we have people who weren't committed to getting where they were getting committed. It's because they slipped. They deviated from the basic principles of how we provide unselfish, professional, proficient, empathetic service every day to the people we're taking care of. And when things are getting really, really tough out there, and that happens when you're frustrated because this has happened, that's happened. You know, this is my third call for a sick subject in a row, and the second one that's vomited on me, and the first one didn't need to go to the hospital and didn't want to go to the hospital. When you're getting into one of those days, remember, it's when you deviate from these principles that we wind up hurting somebody. So what's the most dangerous thing that we do in the field? What's the most dangerous thing that we do? Is there a particular drug that we administer that we make a mistake with more often than not? No, it's not that. It's not defibrillation. It's not intubation. It's not any procedure we do. The most dangerous thing that we do in the field is leave somebody there. When somebody calls 911, for the most part, they called for a reason. Something was really bad at the time that they called. And there are times when we get there and there's a refusal and it's a justified refusal and things make sense and we can put it all together. But it's when we get lackadaisical about the assessment or when we try to talk somebody into a refusal. Those are the dangerous ones, and those are the ones where I get the call that says the next day that the next unit got there the next morning and found a patient dead in bed in the morning and somebody had been there the night before. And I know that as a medical director, that's horrible to see a situation like that. I've never seen a provider go through that who wasn't devastated by it. It's about paying attention to detail and, for lack of a better phrase, maintaining a tight sphincter tone with every one of these people. When somebody calls for help, that something went wrong, somebody needed help. Believe it, pay attention to it. If somebody else is there trying to minimize the complaint, don't. Go through a process of evaluating everything. If you feel like somebody needs to go to the hospital and they just feel like they're going to refuse, get online medical direction. Get your supervisor there. Get whatever you need to get there to get to the answer that you think you ought to get to. So now we're off to a couple other topics that just don't necessarily fit together on the slide, but we'll just kind of walk through them, because these are things that I hear on a regular basis from our providers with regard to, hey, why aren't we doing this, or why are we doing this, or what are we doing with this? And the first, the one that I hear about most often is use of end-tidal CO2. And I think I got this. I delved into this with the supervisors when we talked at Stevenson College a couple of months ago, and I think I took a beating on this topic, and nonetheless I put it back up again for a response. So there's a lot. If you look at EMS around the country, there's a lot of people who have given up nasal prongs entirely and have gone to measuring end-tidal CO2 on every patient with nasal capnography, every patient they encounter. And that is absolutely, positively a waste of money. And Rich talked about it. We're not a department that is wealthy enough to do that for every patient. If we felt like there was going to be a clinical benefit to it, we would be talking a different story. But there ain't a shred of evidence this is a clinical benefit to that. There is evidence that people make money by doing that. And there is evidence that there are people around the country advocating for that who are getting paid by the companies that sell that. So much of what you hear about that may not be actually based in evidence. But there are times when the use of nasal capnography is extremely valuable. Inside the hospital, it gets used a lot more than it does in the field. So why do you think that is? They don't have one-to-one care like we do on a regular basis. We have one patient to one provider. We can have somebody watch the patient breathe and tell when they're breathing. Not all the time. There are times when that won't work. But for the most part, if you give somebody a couple milligrams of morphine or some fentanyl, or you do something for pain relief, you ought to be able to have a conversation one-on-one, not leave that patient, and know that they're continuing to breathe. And when they stop, you don't need to look at an end-tidal monitor to tell that they stopped. You can pick that up, because you're smart enough to know who's breathing and who's not breathing in front of you. When we administer conscious sedation, and that means a narcotic plus a sedative, plus a benzodiazepine, that falls into the category of conscious sedation. And I would say that in the United States in 2019, the standard of care requires monitoring end-tidal capnography for that patient population. We don't do that very often. We usually give one or the other medication, and we provide one-to-one care throughout that entire time. There are very few other situations where the use of end-tidal capnography is going to change what you do for the patient. So people have talked about looking at end-tidal capnography as a means of diagnosing sepsis in patients. I would argue that it is a tool for diagnosing sepsis. It is one piece of information. How do we treat sepsis in the field? We transport to the hospital, okay? So if they have sepsis or they don't have sepsis, how does that change what we're about to do? It doesn't change what we're about to do. We need to, when we suspect that somebody may have sepsis, we need to communicate that clearly on arrival at the hospital so that the priority goes up. But we're not going to decide, if somebody's going to make a decision about, based on an end-tidal CO2, who goes into a waiting room to wait for a bed and who goes directly into a bed, that can happen when they get to the hospital. That doesn't need to be us. We need to be a little bit careful about how we use new technology so that we're being cost conscious about it, but it's available. And we want you to use it when it's appropriate. We want you to use it when there's value to it, but the number of situations is preciously small when that's necessary. And I can tell you that approach, which I think is shared by all of our medical directors, is not common around, it's not as common around the country. And I'm not sure why it is, but all I can possibly glean from it is that we trust our providers to look at the patient and tell when he's breathing or not breathing, or she, better than other people do. The first slides we showed probably suggest that we're right in doing that. Along the lines of what's new, what's happening, and what seems to be difficult for people to comprehend. Scope of practice violations. And this is not, I'm not talking about any specific incident that's occurred in the county, but I can tell you that over the course of the past 2 years, I would say, we've seen more and more of a situation where a provider is credentialed in Baltimore County as an EMT, has a license as a paramedic, is licensed by the state as a paramedic, maybe practicing in another jurisdiction as a paramedic, but is credentialed in Baltimore County as an EMT, and gets on one of our units and immediately decides, I'm a paramedic, I'm going to function like a paramedic. You're not credentialed as a paramedic in Baltimore County until you're credentialed as a paramedic in Baltimore County. I'm licensed in the state of Maryland as a physician and surgeon. I'm actually licensed to do brain surgery. I'm not credentialed anywhere to do brain surgery because I'm not qualified to do brain surgery, but I'm licensed to do that. The difference between licensing and credentialing is important. It means that somebody has looked at your actual qualifications and said you're qualified to do that. It's because you hold a paramedic card doesn't mean you're necessarily checked off to work at that level in that jurisdiction. I practice as an orthopedic surgeon at shock trauma, so I probably know how to rod a femur in any operating room in the country. But if I go over to Hopkins today, I can't rod a femur in the operating room at Hopkins because I'm not credentialed at that institution to do it. And the penalties for functioning in that type of situation, well, there's not much Hopkins could actually do to me, but they wouldn't let me do it. You wouldn't be allowed to do it. So the same thing is true for EMS providers. Licensing and credentialing are two different things. And it's important that we respect that differential. It allows us, by credentialing, it allows us to know who's out there, who's doing what, and that they're functioning at a level that we find acceptable for this county. And that they've been introduced to how we do things in this county. They understand our system of responses and what we do and how we do it. They may be coming from a different jurisdiction where things get done differently, and I can tell you that there are, without naming any specific jurisdictions, Baltimore City, there are nearby jurisdictions where people do things a little bit differently than we do. And I don't know what's acceptable there or not. I know what's acceptable here and what's not. And they don't always match. You're just gonna have to trust me on that. So we're gonna work to make sure that the process for new people coming into the county is as smooth as it can possibly be. We want people to come in here. We want people to participate. We want them to work. But we want to make sure that they understand how we approach things and how we do things. Everybody's gonna get a skills check that does that. But we're gonna work to streamline the process, the credentialing process for providers coming in. All right. On to the topic of what's new and fun out there. How many got this thing called mobile integrated health and community paramedicine? Right? Just about everybody has. It is an exciting new area of EMS without question, and it's got tremendous potential to change the way that people use the healthcare system. But I think it's very important to understand exactly what it is, what it can do, and how it works. So mobile integrated health is and community paramedicine. Community paramedicine is the tool through which we administer mobile integrated health. It's a two-pronged tool. The first is the proactive responses. In the context of a population health engaged in an experiment in population health care, it's an experiment that's a partnership between the state of Maryland, between the Department of Health, and between the federal government, Department of Health and Human Services. And the experiment is unique to the rest of the country, and it involves making sure that we are managing the care of people in a way that decreases their need to utilize high-cost services like hospitals. In that proactive response, we identify vulnerable populations. People who are likely to need EMS services, are likely to need to be readmitted to the hospital. We know patients go home with congestive heart failure after a hospitalization. Their likelihood of being readmitted within the next 30 days in some areas is up to 30 or 40% that there's a chance that they're going to have an exacerbation of CHF and need to be readmitted. We also know that a lot of that is driven by failure to take their meds properly, failure to do things that are going to reduce their risk, and completely, or not having access to the tools that they need to get back into the healthcare system afterwards. Not having an understanding of what their discharge instructions were. And in models where people have used home health care or community paramedics to go out to the house to assess the social determinants of health that are contributing to their ability to follow their instructions, to make sure that they're measuring their weight every day, that they're not retaining more fluid, that there's not a need to adjust their medications, to do everything that's necessary to prevent that population from being readmitted to the hospital. People have demonstrated around the country that paramedics are a great tool for that. They already know how to drive to your house and help you. And they tend to be pretty smart, they tend to be pretty resourceful, and if they've got access to your electronic medical record and they're in communication with a doc at the hospital who's part of the team that discharged you, there's a lot that can be done at the house in that proactive model to reduce the chance that you're going to be readmitted to the hospital. You say, how's that different than what a home health nurse used to do? Well, it actually is different because home health nurses actually don't have the same flexibility to call the doctor and respond to an evaluation in the same way that paramedics do. Medics are probably better prepared for that. In some areas, for that. They are also very prepared to do that kind of thing, but they cost, frankly, more than we do. So the community medicine model is a very, very good model for that, but it works when it's integrated. It has to be completely integrated into the patient's medical record, and you have to, you're not responding to a 911 call in that situation. You're proactively going out to the house to look at that patient and to evaluate them and do something. The second piece of mobile integrated health is the reactive responses. Baltimore City's recently developed a pilot program that has both components of this. And in the reactive response, there's a piece that says we're going to look at that patient population that's already under our care in this model, and when they call 911, we're going to go out and respond and see what we can do by integrating with their medical record and their doctor to address their problem at the house. But there's also the other programs that are attached to this called EC3, Emergency Triage, Treat, and Transport, that I'll talk about in a second. Those programs are designed to decrease the need to transport people to the hospital, to the emergency department, who have already gotten into some level of problem that caused them to call 911. I would argue that this first area, the proactive response, is absolutely unique and has tremendous opportunity to save money, because it'll save the need to admit people to the hospital by addressing their challenges before they get into trouble. After they get into trouble, they need some treatment of some sort. Maybe we can do that at the scene. But when you say, what are you saving in that situation? If you bring them to the emergency room, you should be able to deliver that same level of treatment in the emergency room, right? And you'd say, it's cheaper to do it at the house. I would say, it's not. Yeah, the amount of time that you lose in driving out to the house and driving back makes you much less efficient than delivery of care in the emergency department, where you've got a team that can run a bunch of patients through at the same time. The other thing people say is that if you don't take them to the emergency department, they don't get admitted to the hospital. That to me makes almost no sense at all. Somehow a local emergency department doctor can't help himself from admitting the patient once he shows up, but you're supposed to, the community paramedic is supposed to decide in the house that that patient doesn't need to be admitted to the hospital. The first piece of this mobile integrated health model is where we can really make a difference. In the second piece, there's value in the triage, treat, and transport piece in that we can provide some convenience to patients. And what Medicare, what CMS is about to do is engage in a series of pilot programs, and there will likely be jurisdictions throughout Maryland that apply for those pilot programs. We may or may not apply as a jurisdiction, that's to be determined. But the pilot programs will allow for a payment from CMS to the EMS agency in certain situations. So what are those situations? Well, we'll decide to transport an individual to another destination other than an emergency department. There will be an opportunity to get paid. So right now, if we decide we're going to transport the patient to patient first or to his doctor's office, you can't get paid for that. The EMS will be able to get paid in some of these pilot programs going forward. If we provide treatment in place with a qualified healthcare practitioner, in other words, if for some reason we develop one of these programs and we have a nurse practitioner who's riding along with our units and delivers care at the scene, we'll be able to pay for that care. So you'll be able to make it sustainable long term and not bring those patients to the hospital. Where mobile integrated health really works as a system is when you combine all these things together, so that you've got a unit out there that on a day-to-day basis is able to go out and do some triage and some treatment and avoid some transports and still be able to generate revenue for it. But really where it makes sense is when it's going out to the house proactively in advance and making sure that patients understand the care that they need and that we're identifying barriers to them getting the care that they need to keep them from requiring to go back in the hospital. The programs that CMS is going to be establishing encourage establishment of medical triage lines at a 911 center. So using nurses and advanced care practitioners at 911 centers to help tease out over the phone who the best candidates are for this type of program. That has to be in place to be eligible for the grant. Reduces unavoidable transports and reduces unnecessary admissions to the hospital. So, this is from the CMS website. The EC3 model aims to reduce expenditures and preserve or enhance quality of care by providing person-centered care such that beneficiaries, Medicare beneficiaries, receive the appropriate level of care delivered safely at the right time and place while having greater control of their health care through the availability of more options to them. Encourage appropriate utilization of services and encourage efficiency in the EMS system to more readily respond to and focus on high acuity cases so that we can spend our time in high acuity cases and we can decrease the number of people who are calling on a regular basis for service by providing them care that they need. All right, on to the next topic. Any questions about that, about mobile integrated health, about what it is? Decision as to where we're going to go with that is to be determined. Medicare is not going to start releasing these programs for bid until, I believe, June of 2019 is when the bids come out. And at that point, there will be some jurisdictions in some parts of the country who get involved in these pilots. And some of it will be competitive based on how they respond to the bids.
Has there been any consideration of the opioid crisis in developing a Suboxone program that mobile integrated care could participate in? In one of the EMS conferences I went to recently, they were having remarkable success with a Suboxone program that was actually funded by the insurance company because they said they had so many claims that it actually saved them so much money that the insurance company funded the program.
Yeah, so I'm not to repeat the question. So the question is, has there been any talk about adding a Suboxone program for opioid overdose to a mobile integrated health program? First, the mobile integrated health program, the pilot that's being developed, is being developed by CMS for Medicare beneficiaries primarily. It applies across the board. But for the most part, Medicare beneficiaries aren't the opioid overdoses. Now, not exclusively. I'm sure somebody's going to tell me a story about a Medicare beneficiary and an opioid overdose, but to a large extent, that's not the population. Quite frankly, the field, from what I've heard from the psychiatrists about Suboxone administration and prescription, they'd be very nervous about that approach. I'd be interested in seeing how it's been used and whether or not there's success. But I don't know. Sean, have you heard? Yeah. Jeff?
Suboxone is very tightly regulated by all kinds of new providers who limit how many patients have on Suboxone.
Yeah, it would require a bunch of waivers and things. And be very, very difficult. All right.
It's not as expensive as hospital.
We heard from, and you've heard from me incessantly over the past decades, that one of the greatest challenges that we have to delivering timely care on a day in, day out basis is how many units we have tied up in emergency departments waiting for a bed. That's a problem that's not new, and I always hear it's getting worse. Well, the truth is, if it were continuing to get worse every time we talked about it, we wouldn't have any units at all to be on the road. They'd all be waiting in emergency departments. It's probably not getting worse, but it's not getting better. Although I have to say, this is as bad as I think I've seen it in a long time. We have routinely very prolonged wait times, and we have standard operating procedures in place that I believe we're not following all the time. And I think we're probably not following them all the time because we feel like they're not going to help. They're not going to make a difference. And I can assure you that if we do this and we follow these procedures, they will make a difference. It will help, but we have to do it. Emergency department, lots of reasons, quote unquote. One of my favorite terms, reasons. Reasons and excuses are synonyms. But lots of reasons why they can't unload the patient from your stretcher despite the fact that the law mandates it. And that reason is we've got patients boarding in the emergency department who need beds upstairs. Okay, so understand that approximately 40% of my day-to-day job now is as a hospital system administrator. So I'm now one of them, one of those suits who deals with these problems and says these are the problems that we have that we can't get by. But I'm still here to say it doesn't matter. The emergency department is part of the hospital. It's their problem, it's their job to fix, not ours. And it's not ours to worry about. So when they tell you that I've got too many boarders, I can't put your patient anywhere, that's interesting, and it may be true, but it's their problem, not our problem. Our problem is that when somebody calls 911, we have to answer. We don't have an excuse, we can't have a reason, and if the reason is that it takes 15 minutes after somebody collapses with cardiac arrest, it takes 15 minutes for us to get to the scene. If that's the reason is because we were in the emergency department, it doesn't matter, the patient's still dead. Okay, so that's not okay. We have to be able to respond to 911, to when people call 911. That's our primary job. Everything else is sort of gravy. So we have to be able to get out of the emergency room after we get there. We have procedures for what we need to do in order to limit our times in the hospitals. So first and foremost, when there are enough units on the street, when our district is well covered, we can sit in an emergency department for a period of time and not affect our ability to respond. It may not be convenient for career volunteer units, whomever. It may not be something you like to do to stand there, but the fact that we don't like standing there is a lot different than the fact that we have to be in service. But we can tolerate that situation differently than a situation where there are no units in the region and somebody's got to be available to respond. On an individual unit, you won't necessarily have visibility to that. Your DO does, you don't. This is why, regardless of the fact that your DO may not be able to do anything about the situation, it's tremendously important that at the 15 to 20 minute mark, you let them know, I'm sitting here waiting. Because if your district officer hears that from multiple units at multiple times, he or she knows My red flag needs to go up. My yellow flag needs to go up. We need to do something to be able to make sure that units are available to respond. If they don't have that information, if they don't have that situational awareness that you provide to them, they can't make decisions that are as good. You need to, there are going to be times when you get irritated by the wait time in the emergency department, and it's never okay not to remain respectful in the interaction with that. We never advocate for that. But there are going to be times when it's necessary, based on an assessment by your district officer, based on the awareness and likely the presence of the shift commander at the time, and based likely on the awareness of one of the medical directors, when it's necessary for us to tell the hospital, I'm sorry, we just can't stay here anymore. We're moving our patients to one of your stretchers, and we're leaving to get back in service. Or we're going to leave our stretcher here, somebody's going to bring us a new stretcher, and we're going to get back in service. Those things may need to happen. No individual crew should ever make that decision by themselves. That should always be a decision that involves leadership at many levels. But there are going to be times when we may need to make those decisions in order to be able to meet the needs of the citizens that call 911. Did you want to say something?
Yeah, just a prime example with that. With the EMS ones being up in the EMS office during the day, that's happened twice, where we've had the EMS one go out, and again, as we hear of that stuff, and we were able to respond fairly quickly, that we cleared units out of the hospital, once by a phone call, once they actually responded over to the unit, and they have a few other strategies to deal with them, and it's worked, so please let us know when that stuff happens.
30-minute timeline now is, that's a consistent thing. I mean, we have units. That's a good thing. Yeah. Oh, yeah. We're getting notified, as district officers, we're getting notified on a daily basis that hospitals are holding our units for 2, 3, 4 hours. And we told them we need to change, we put patients in wheelchairs, we put patients on stretchers, but we're still trying to hold our units.
So if we can put patients in wheelchairs and put them on stretchers, that's a decision we need to get to before 2 and 3 hours. If they can go to the waiting room, if they can sit in a wheelchair, if they can do something else, we need to get to that decision sooner.
Well, then we need some guidelines as to how that's going to happen, because as of right now, we have hospital staff telling us that they're not able to put these patients in wheelchairs. They refuse to give us the stretchers, they refuse to give us wheelchairs.
So that's got to get kicked up. That's got to get to the shift commanders. They need to know about it, and they need to be kicking it up. And we'll help with guidelines. But if you've got somebody who could be in a wheelchair or be on a stretcher, you got to be back out on the street. It can't be about convenience. It's got to be about making sure that we can respond in a timely fashion to 911 calls. But you know what the district looks like at that point in time. And if you're getting like that, you got to kick it up. And that's got to be we have to use that tool. I can tell you that the state understands that. By the state, I don't mean MIMS, because MIMS really has not chosen to react to this. But by the state, I mean OHCQ, the Office of Healthcare Quality. They hold the hospital emergency departments accountable for the care of those patients, regardless. Once you cross the threshold onto hospital property, there's actually case law to suggest that it's when you get within a block of the hospital that this occurs. But once you cross the threshold onto hospital property, it's their job to take care of the patient, not ours at that point.
Right now, we're really just a courtesy section of emergency medicine healthcare. I mean,
Yes.
that's what we're doing, and that's not fair to our providers, because they're getting people.
I agree.
I can tell you, Dr. Pollak, we've left the B shift. We have left the paramedic in the stretcher in the hospital, put the medic in service to go over to one of the stations that has reserved stretchers, pick up that stretcher, put that medic unit or BLS unit even back in service. It worked a couple of times I've seen it.
And it sends a message to the emergency department that they're in a crisis mode. And that's what they need to hear, is that they need to move to crisis mode when we're getting that problem.
I've been on both sides as a ER nurse and a paramedic, and I waited 2 hours and 20 minutes at the hospital just a couple of days ago. But as a patient...
Probably one of our hospitals.
As a patient advocate, though, I have a hard time leaving that 85-year-old lady with chest pain on AMBO 2 stretcher in the hallway because I care about my patients.
So when you've got a patient, so what Beth, I'm repeating the questions not because people can't hear you in the room, but because people on the live stream and on the webinar can't hear unless I repeat the question. What she suggested is that we have a problem leaving the patient and abandoning the patient in the hallway when the patient has a critical condition that really doesn't warrant being abandoned in the hallway. And I would tell you that at that point, we've got to kick it up again and make sure that the hospital understands that you got an 85-year-old patient with chest pain. Okay, that patient shouldn't be under your care in the hallway in the hospital. That is the hospital's responsibility, and you're not credentialed to deliver care in that hospital. They need to find somebody to take care of that patient.
It's difficult to take that patient off the monitor, and I always ask for and document that I got permission from nurse so-and-so to remove the monitor. Does that take any of the burden off of me?
If you've got permission to remove the monitor and it's clear that the patient does not need a monitor at that point, that's different. But if you've got a patient who needs a monitor, it's not acceptable to take the patient off the monitor. Those are situations where we're going to make, that's different than the patient who can be transferred to a wheelchair, okay? We've got enough opportunity in the patients that can be transferred to wheelchair who are of lower acuity that we can get units back out in the field. But when they're ignoring somebody with chest pain for 2 hours in the hallway, hey, that's an EMTALA violation in and of itself. EMTALA violations, the Emergency Medical Treatment and Active Labor Act of 1985, something like that, requires that hospitals provide emergency care and emergency triage in a timely fashion. And 2 hours is not timely fashion for somebody with chest pain. When you report those things, when I get those reports, when somebody sends me a cogent description of that in writing, I don't investigate them on our end. I forward them to OHCQ. And hospitals talk about it was when they were sitting in front of you, all right? We're not going to waste resources talking to hospitals about that. That's going to OHCQ, and I can tell you that multiple hospitals in this county have been fined $25,000 a pop for violations like you just described. Write it down, send it to me. I promise you I'll send it on.
So this may be a different. One of the attendees said, how do we address the hospital system that will not go on red or yellow and refuse to acknowledge our officers' request to do so? To repeat the question, how do we address the hospital system that won't go on red or yellow and refuse to acknowledge our officers' request to do so? Did you want to add to that question, Mike? It's complicated.
Yeah.
All right? Because now we're going on blue alert. Northwest told me the other night, well, why should I go on yellow? You're on blue alert. I can save my yellow alert out. That's the answer. It's become a complicated. We throw down A's, they throw down 2 pair. And it's continuing.
We need to decide how we're going to manage in that situation. So it's not about how busy they are, it's about how long the wait times are. So we need to so in that situation, as a district officer, your job is to figure out how badly impaired the response times are in the region and respond accordingly. We can't tell them what to do in terms of red and yellow. There are no specific criteria.
And honestly, in my dealings with the ER, the problem is not the patient who can sit in the wheelchair, because they're more than welcome to put him in the wheelchair. They're more than happy to put him in the wheelchair and put him out in the ER. It's the putting him in the wheelchair because there's a danger of them falling out, and they're probably really because they fell out of bed and they got the nursing home, right? With our units sitting
Stretcher with rails.
well,
Yep.
gotta have a stretcher.
Yeah.
If I could just mention, I mean, and this is something we don't have to trust it. The one thing I didn't talk about with all the changes is just let them look down at MIMS. So right now at MIMS, there's a new executive medical record that just started. There's a new state medical record, and there's several other people. Literally, this is their first month. Within the last month or two, this is real high on their radar, and I know that's something that they're committed to trying to get fixed. We do have to give them a little bit of time. We're not going to fix it tonight. Wish we could, magic bullet, but I know this is something that they are actively looking at and working on.
You were next.
As far as the 20-minute mark, that's when most of our units are getting triaged. 20 minutes from one person is there. My question is for you then, Michael. Are they thinking about changing alert statuses? Because yellow is misused and wrong.
that system, I'm not clear now, the color system as it sits right now doesn't work.
It's this,
Worst for hospital wait times in the nation. There's been multiple discussions. I'm not.
there aren't better systems in the country though for these different alert times, because there is some subjectivity to how the hospitals use them, and how the hospital administration penalizes the staff for using them or doesn't penalize the staff for using them.
And each hospital has a different criteria of when they can go on.
Absolutely.
That's also good too, because Maryland General has 2 patients in the ER and 2 ambulances that they're like, oh my God. And then you walk in St. Agnes that has 12.
Midtown it's called now, but Charlie.
Dr. Paula, you've been here for about an hour and 15 minutes. We've had quite a few speakers, and everyone's been listening pretty intently. You brought the subject up, and then we're getting plenty of response from the audience. Earlier, beginning, you showed some stats from the SAVES cardiac arrest versus Baltimore County.
I started with the good stuff, remember?
From Baltimore County to the city, to the state, and whatnot. And that was interesting. My question to you is, because we're all seem to be up in arms about this, what is the average wait time in other large cities like LA, Chicago, New York? You never have that gap.
Yes. So we're worse. Right. It would take the next hour to go through GBR, population health management, total cost of care, and what we're doing in Maryland that makes us worse than the rest of the country right now. But I would tell you that the reimbursement system is different here. And that ambulance wait time is not a metric that's attached to a specific penalty yet for reimbursement. It will be, I hope, in the future. I wish you could hear me at the Maryland Healthcare Commission talk about this, and on record, you're the only one saying this. It can't possibly be as bad as you describe. And
other jurisdictions aren't voicing this as a
no.
they're just accepting that this is.
Well, there's nobody at these in these forums who really has visibility on it or cares about it, right? So I have a unique ability serving as a fire department EMS medical director and serving on the healthcare commission to be able to communicate this stuff. But what I'm saying is, I hear what you're saying. I'm reiterating what you're saying. These are some tools for managing through it, but it's not perfect. This isn't the perfect solution to getting through it. A couple more questions.
Just as a quick interest, for how's that Google? I Googled the emergency room wait times by state. Right now, in the state of Maryland, the average wait time is 46 minutes.
That's not an EMS wait time. Right.
Right. California says 27. New York City says 27. Most everywhere else is in the 20s. Maryland is in the 20s.
Yep. We had a micro-regulated healthcare system in Maryland that was costing more and underperforming the rest of the country. And in our infinite wisdom in the state of Maryland, we decided that the solution to that was to increase the level of regulation. And with micro-regulation, unless you're specifically regulating that particular metric, it doesn't get better. I think we need to specifically regulate this particular metric here, but that's more to follow. I think the new leadership at MIMS will help us do that, because the rate limiting step, it's not that MIMS has jurisdiction over this, but the rate limiting step to groups like the Health Services Cost Review Commission that decides how much hospitals get paid, the rate limiting step to them regulating this issue is having access to the data necessary in order to verify what's happening. And ambulance wait times, if we can get accurately report on that, would be a way to do that.
I'm listening and with this and talking about the DOs and so on and so forth, and the things since I've been back, the things that I've had DOs pull me with, and the captains pull me with, is they're over-task saturated with this, their calls, the computer, so on and so forth, and there's not enough supervision out there to handle what all they want them to handle, and compare that to the suppression side, all right, where are we going with that? We can say we have quality of care, and it's great with what we're seeing. We're beating up our troops and doing it.
Yeah.
And I understand what you're saying is be an advocate for your patient. Bang your fist at the hospital.
I didn't say that.
I know, but you're saying
No.
be forward.
No.
Be forward. Talk to the
Escalate it. Escalate it, right?
Okay.
Kick it up the chain.
Okay, so we should
Bang your fist at the hospital is not what you do.
Okay.
All right.
But the 20 minutes,
Yeah.
the 20 minutes that we're talking about, all right, the district officers be camping out at the hospitals.
No, it's just notifying the district officer at 20 minutes.
So,
All right.
so the district.
It's not, yeah. It's ASAP, but that's not a response. You'd be there on every call.
So Stan, I'll ask you this, if that is a concern, why didn't the union make a reorganization of paramedic negotiations?
So we're probably
Because it's not working.
off. We've probably moved a little bit off of topic here right now, and I understand that the local may have some things they want to talk about with this, but I'm just going to suggest that maybe we take it to a different venue afterwards. But last question on this issue, and then we'll move on.
So obviously, in this room, everybody here has been understanding that this is a huge issue. We all know about it. It has gotten worse. Whether or not the data shows it or not, it's gotten worse.
I agree.
For the nursing staff, I mean, his full data is there. I mean, the attitudes that we've been getting from the nursing staff and the administration has not improved. That's only gotten significantly worse. I mean, I know my crews immediately have documented pretty much every single call that they've gone on the last 2 or 3 trips because we've had issues to some significant degree. This is fantastic because it's a policy that we have right now, but we don't have education as to seeing some of our guidelines as to things that we can do to clear our units out of the hospitals quicker, outside of putting people in wheelchairs and putting them in stretchers. We have to have some sort of education amongst the district officers even further in saying we can do step A, B, C, and D if that's not working.
So, point well taken. I think we're looking for things that we can do for the district officer education programs. I think this is one thing where we can go into a little bit more depth on what we can do to give you to help address these situations in the field. And I think the number of times this is happening probably exceeds the ability to use the shift manager to be at all these things. But I hear you. I hear it loud and clear.
With the what?
The EMS ones.
But the point is, you're pulling the EMS ones during the day off the street, all right, and you're increasing the load on the EMS officers who are out there.
No, they will leave when it happens. So that's what I'm saying. They're going in with a little bit different way than what I'm going to paramedic to talk to the ER staff because, quite frankly, we want to keep it away from them.
I got some more things I want to cover here tonight, so let's. We could get stuck on this one for a while. So this is important. All right, we have. I think since I've been medical director, one of the I'll pick on the local here, but since I've been medical director, one of the best parts of this job has been the commitment of everybody around me, including and especially the guys in the local, to quality and to building quality and to addressing problems when they occur in a fair and equitable fashion. And I think that's been something we've done jointly from the beginning, and that has made this jurisdiction, I would say more than anything else, wildly different than the city, where they're fighting constantly. And I think that the approach that we've often used is one that says that to err is human, and that's the title from a report from the National Institute of, I don't remember the name, the National Institute of Science, but the Academy of Medicine from 1999 that talked about the number of errors that are occurring in medicine, and today we believe that safety violations and errors in healthcare are responsible for upwards of 250,000 deaths a year. Possibly the 3rd largest cause of death in the United States is medical error in the hospital. And there are 2 types of providers in the world, and I've been saying this now for 20 years. There are those who admit that they make mistakes and those who lie about it. But nobody's perfect. And we don't expect you to be perfect. We just expect you to try to be every day, to try your best. And you're going to make mistakes. We're going to find out about it. You're going to tell us about it. And we're all going to get better because we learn from those mistakes. And we're not going to penalize mistakes that occur in the context of people who are trying to do their best for the patient at the time. So systems have to be developed that limit propensity for human error. And when we learn about errors that occur, we learn about things that we can do within our systems to decrease the risk of error. People have to be honest in their assessments. And you can't be honest if you feel like somebody's going to take your head off when you admit to a mistake. We're not going to do that. But fairness requires that there be accountability also. So when people are not doing their job, when the mistakes aren't made in good faith, when errors are egregious, or when risks are egregious, there has to be willingness on the part of the organization to step up and say, you know what, that's over that line. So we've been talking about this for 20 years. The Joint Commission over the course of the past 5 years or so has developed this concept of just culture, which embodies those principles that have been in the literature for a long time. We didn't make we read what other people have been doing, and we adapted also. But they built this just culture algorithm and process that we are in the process of formally adopting in the county as a way of evaluating quality in EMS, errors in EMS, and challenges in EMS that helps us in a structured fashion decide how we approach these things. And the algorithm is very complicated in looking at it from where you are, and I'm not going to expect you to sort of get out of it, but it starts with the first one. Was the action deliberate? If we made a mistake and we did something wrong, did we do it deliberately? In healthcare, how often does that happen? You did it deliberately. Most people, there's an inherent goodness in people that go into healthcare. They're there to help people for the most part. That describes 99.9% of us. That's exceedingly rare that happens. But if it was deliberate and it was intended to cause harm, that's sort of the type of situation where we immediately intervene and stop things from getting worse. But in walking through the rest of this algorithm, you get to these different types of categories. There's reckless behavior. So what's reckless behavior, right? So when you're driving down piss somebody off. If you're doing 70, is that reckless behavior? Not really. If you're doing 130 on the Beltway, there's no excuse for that, right? You're putting everybody at risk. That's clearly reckless behavior. When you get to areas where you get to reckless behavior, that's a different type of discipline. But there may be system failures in place too that led you to do that. If you get to at-risk behaviors, there are behavioral assessments and coaching that we can use to respond. There may be system failures. This algorithm may take you to the yellow box, which says it was human error. That's education. Okay, that's that we use to respond to that. And there are always things called system failures and cultural drift that occur. Cultural drift, I think, is one of the most common challenges that we see in EMS. What's cultural drift? That's where, we know that everybody who has a mental status change should probably get a blood glucose measurement. Yet, in some situations, you got somebody who's maybe had a few drinks and you start to feel, well, maybe it's not necessary for this individual, and we culturally drift away from things that we know by protocol we should be doing. Now, I don't need to bring the monitor on this call because I know this patient, I know what's going on here. Yet we know that the call, the way it came out, says the monitor goes in. Yeah, those are things that happen every single day in this department. I get it. And when we get to the point where we've got a really, really just culture, people will learn that when you fail to bring the monitor in on a call like that, and you get back after the call and you realize, hey, I probably should have, and you report yourself for it, and you say, how did we get there? I want you to identify when the error occurred, when the drift occurred, and self-correct it, report it. So we can teach other people, hey, we know that this has happened 15 times, but don't drift, don't make that mistake in that situation. I'll give the example of So Rebecca Frederick is a former EMT from Reisterstown who is now one of our quality directors at the medical center downtown, who has been helping us deliver this program. And she uses an example that she's used in front of most of the leadership of the University of Maryland Medical Center, as well as a bunch of our leadership in the first presentation here, of a nurse was taking care of a patient and was giving rocuronium on a regular basis throughout the night. Patient was intubated in an intensive care unit. And each time he gave the medication, he checked the medication, scanned the medication first, and then administered the medication to the patient. Except the third time, at about 4 o'clock in the morning after being up all night, multiple things going on at the same time, he grabbed the medication out of the cart, gave the medication, scanned it, got a buzz from Epic, from the electronic medical record, not prescribed for this patient, and realized that he had taken the medication from a similar colored box, one shelf below, and given the patient a potentially lethal dose of an insulin that shouldn't have even been in that box. Reported it right away. Everybody addressed it, but the issue here was one of drift, right? And then administered it. Had been doing that all night, but for one reason or another, one process got in front of another process, and he made a potentially fatal error, medication error. Wasn't fatal, got fixed, but it describes the danger in cultural drift. And we get into these situations all the time, where you're given a medication, you got 5 R's to go through, you're supposed to do them out loud, you're supposed to check them with somebody else if that other person's there. Maybe you drift away from that at some point. Not a problem until it's a problem, right? We need to develop a culture that says that we know we're going to do this. We're going to walk through that checklist with every medication administration. We're going to do it every time. We're going to do it every time the same way, and there aren't going to be exceptions to it. The Just Culture Toolkit gives us a structure for addressing what happens when we identify human error, what happens when we identify at-risk behaviors, and what happens when we identify reckless behavior. And I'll let Rebecca at some point come and give one of these sessions, because she does this in a 2-hour format, and this would be an ideal group to do this with. But it really helps you understand. I'll have to tell her that I gave away her example, or her case example, but I'm sure she's got more. But it helps you understand and put things into boxes in terms of what's an acceptable, what's a mistake that represents drift, cultural drift, what's a mistake that represents human error, what's a mistake that represents reckless behavior. We've done this now in a couple times in our QA reviews, and it's helped us, I think, review and understand which errors made by providers warrant education, which errors made by providers warrant attention to system changes, and which errors made by providers warrant something along the lines of a disciplinary action. And like most of them, which warrant a combination of those things. So next steps in this: further education of supervisors, use of the Just Culture tool in evaluating safety and quality concerns raised in QA sessions and case reviews, and continued work to develop a culture of accountability. That's our ultimate goal here, is to develop that culture that where people believe it's safe to speak up, where people believe it's safe to identify when errors are made. I think we're better at that than we were 20 years ago, but I don't think we're where we could be. And Rebecca's described this situation where there's a tiered approach to things, where you go from, first of all, reporting errors with machinery and equipment, because that's safe, right? No piece of equipment is going to get angry with you for reporting that it didn't work. And then when you get more comfortable with the situation, you report errors that other people made. When you get even more comfortable with the system, you report errors that you made. And then when you get really comfortable with the system, you report intentional errors that you made. Where, yeah, I knew I should have brought the monitor in, and I didn't bring the monitor in. And you sit back and think about it afterwards and say, that was a mistake, and nobody got hurt, but it was a near miss. Again, a couple more topics that I wanted to cover tonight, some of which will likely, well, I don't think anything will raise any terrible levels of concern. The safety issue. So our first and foremost priority in the field is safety. Safety of our patients, safety of our provider, one another, safety for ourselves. We've come a long way in the past 20 years in our use of lights and sirens for transport. We still have a ways to go in our use of lights and sirens and responding to calls, but I think we've come a long way. We don't use lights and sirens to transport priority 3 patients. Most priority 2 patients can go to the hospital without lights and siren, and some priority 1s probably can also. It's extremely dangerous. The lug nut rule is for real. The truck with the biggest lug nuts wins in a collision, and for the most part, we have more lug nuts than whoever we hit. When we get into accidents, we hurt other people, and none of us is out there to hurt other people, and driving like maniacs gets us into accidents. We see this frequently. Rich, you put some of this list together, so remind me what I wanted to talk about.
Just the priority with consults, with priority 1 patients.
Yeah.
As opposed to a notification. Consults being or protocols are for essentially predictable events. But something becomes an ugly case. You start scratching your head on something.
They don't have to know the rules.
Right.
All right. Right.
Us attitude, either on the radio or in the ER, there's no approved attitude. Why would you bring Dr. Watts?
Yeah. Suck it up.
That's what I try to tell them.
Life's terrible. First world problems. Sean?
What are your thoughts about expectations from the hospitals? I know that there are situations where providers aren't calling for the results of their docs. Part, they don't often respond appropriately, right? They're very sneaky, follow the protocol, patients oriented, they can't sort of right, they can refuse. There's not really the engagement, I think.
Yeah, that's a challenge. So just to repeat the question for those online, the question is, what do you do when you get a snippy response from about a consult? You got a patient who's refusing. You don't think the patient should refuse. You tell the doc online, and the doc online couldn't be less interested in hearing from you. Get the name, put it in the record, tell them, I need your name for the medical record on this one. But don't stop, okay? Your supervisors are there. Call them. If you get to the point where you think that this patient should not be refusing and the online doc is refused, and this has happened before, call a shift commander, call a medical director. That's what we're there for those backup situations. We're not coming out to the scene to talk somebody, but I say that knowing that we have a medical director who's gone to the scene to talk somebody into going to the hospital. All right? He's not here tonight, and he's a he, and you saw the list of who the medical directors are, so you can figure it out. But there are lots of us now, all right? Call one of us. We won't get snippy. We'll figure it out. We may not be able to solve the problem, but it won't be because we didn't try. But you got to, I think the patient advocacy mandates that you continue to escalate when you're not happy with the standpoint of the care of your patient. Doesn't mandate that you become nasty to the online doc. You can only get out of him or her as much as he or she is willing to give you. But get a name. Yes.
Would you or the other medical directors be revisiting the policy consulting termination of resuscitation orders for the medical protocol says that that consult?
So you're asking if we would be open to the policy, revisiting the policy of termination of resuscitation. So right now, we mandate a consult for termination of resuscitation, and some of the others don't. Right, that was me. I won't blame any of the medical directors yet, that was me. That was a Saved by the Whistle.
I think that comes from, we have experienced paramedics and such. In these instances, it's 30 minutes into an arrest. We have District Officer that's been on the scene, and certainly some of those experiences that fall outside of the ACS, you want to talk to the doctor just to kind of see why A, but I'm talking like the A system, the embedded A system, the whole time we work with, for whatever reason.
The reason that we did that, it's been a little while, so you had to give me a little time to think, to remember, is because we've got a lot of variability in this county with the level of response at any given cardiac arrest. And a lot of variability in the county with regard to the experience level of providers who may or may not be on that scene. And given that situation, if I knew I had an experienced promoted district officer on every one of those calls, I might be a little bit more comfortable saying we can handle that ourselves. What would it do though? How hard is it to get online direction at that point?
It's a rare instance, but I've had doctors say that they don't subscribe to that mentality.
That we have to fix regardless. So that we want feedback on, that I want kicked up the chain. Acceptable response. Again, it's okay to get a second, it's okay to kick that up. Call EMS 1, call one of us. I don't mind overruling an emergency department physician in that situation. I don't think Jeff or Sean would either, and I know David wouldn't. So. Yeah. It's very difficult to develop policies that apply when there are different people riding in the cars and when we've got different responses in different jurisdictions. And when we're up at the Pennsylvania line, it's a big difference from when the cardiac arrest occurs in front of Station 17. It just is, and we have to have the policy that kind of is able to be applied across all those situations. So, but thank you for bringing that up. Documentation. So this is a pet peeve of mine. The rule is more lenient than it is for nurses. And the rule for physicians, clean, is your documents, your encounters have to be closed at the end of the workday. You don't go home with the encounters open, with the documents open. For nurses, it's even more timely. It's before the end, before the end of that episode of care, that document has to be closed. For any healthcare provider, it's somewhere in that window. Now, what we've said for EMS personnel in this case, expectation, 99.9% level, is that your encounters are closed at the end of the workday, at the end of the shift. They don't carry over to the next day. They certainly don't carry over to the next trick. And there's not a lot of flexibility around that. That's a mandate of the job. When people don't meet that mandate, they're at risk for losing their credentials. Right? At the hospital, docs whose operative notes aren't dictated, whose encounters aren't closed, get their privileges yanked until it happens again. Right? That's pretty telling because it means you're not making a living anymore. We've done that here. We've done that rarely here because most of you are pretty good about getting the encounters closed. It's part of the medical record. It can't wait a week. It can't wait a day. It has to get done that day. It's the patient's medical record. It has to be closed and finished. Hopefully by the end of the encounter, but definitely by the end of the shift. Does that make sense? All right. Thank you.
I try to get them off the highway, I'm afraid to really be involved in the crash as well, which is true. What is, I guess, your insight or recommendation of, it's a bullshit call, get the ambulance, protect your hazard, okay, get the ambulance off the roadway, finish what you're doing, and go start to the hospital, do whatever, but get the hell off the road. And I'm talking fire and everybody, but we have units that stay in the street for stupid stuff. What are you doing? Let's go, get up here. And they just stay, all I gotta do is, let's do it off the road where it's safe.
You don't have to complete your medical records along the side of the road in an unsafe environment. I wasn't implying that.
Checking the patient.
Yeah.
Out to the freaking hospital to get the hell off the road before we go.
Right.
Patient, but every time we go up, or they're there 20, 25. What are you doing? Nothing.
That's why, to be honest, that's why highway accidents is up.
Yeah, but I mean, there's.
Just to be clear, we don't have bullshit calls.
Basic service calls. They can be done en route to the hospital.
The documentation can be done en route to the hospital. Documentation needs to be done in a safe environment. I think it should be common sense that you don't want to document in an unsafe environment. You want to pick a safe place to do that. Right. Common sense isn't always common.
It goes to your point of just culture, right? We've diverted from, we've made a cultural shift from, the rapid assessment, the on scene, to make a decision and go, to this slow down, stay on the scene, take your time, and you're in a vulnerable spot. So it speaks right to the just culture that Dr. Paul just talked about, is that cultural shift that we're seeing.
Yeah, that's the job of the supervisors, to walk up and say, don't sit here along the side of the road with this patient. Move to a safe place and do it. Yep. Yes.
So to go along with that, I do have an interesting question. What about patient assessments for refusal patients on scene of the highway? So I've had accidents on the highway where the patient's going to refuse, but you want to assess that patient, you still want to get off the highway to assess that patient. But you know they're going to refuse, so why would you get off the highway, go into a parking lot somewhere and assess that patient, because they need to go right back to that scene where the police are going to need them on scene?
Yeah, there are different ways to manage that, and I don't want to get into the details of how you manage on scene on a highway, but if you're in the first vehicle that's going to get hit, that's not in the scene, that's a different situation. But if you're in that first vehicle that's going to get hit, it doesn't matter whether it's a pain to get off the highway and do it. Get off the highway and do it, because getting hit's worse.
But the issue of this, if you're going to have, I'm going to have a patient, because it's a minor incident, you know he's not going to refuse, you can very effectively, easily assess the patient, get the information you need, sign here in the dotted line. You don't have to sit there and fill out all your paperwork or in the roadway. You can very efficiently, on a regular basis, you can very efficiently assess a patient, get the information you need for the call you're dealing with, have them sign the paperwork, ready to the scene, get off the roadway, and you have all the time in the world to do the paper report. Not sit there on the scene and pick their nose and talk to somebody and waste a lot of time for nothing.
All right.
On a regular basis.
Rich, that last bullet was yours, Rich. The HIPAA bullet.
Just believe that we got to get them this time for one.
All right. A couple other topics. I want to run through these things quickly, recognizing that we're running low on time. Minimizing complaints continues to be our biggest concern, and this is that cultural drift to say that this patient that I'm looking at, whom I've transported 3 times in the past month, who's been in this same emergency room twice in the past day, who acts like he or she has having a mental status change on the stretcher next to me in front of the nurse's station. I'm just going to ignore that and move on, because I know this patient. I walk down the algorithm of waiting that. That minimization of what's going on, that cultural drift away, is amongst the most dangerous things we do. And I can tell you that patient I just described as a result of it. You can never forget that even when they're calling you all the time, and even when they're faking half the time, some of the time, it's going to be real. Faking, they're not faking because they're looking for something of an underlying psychiatric illness causing them to do that. Never assume that somebody's okay. Don't minimize complaints or problems that you see until you've proven else is not there. ALS incidents and cardiac monitors, I think I've already covered. They're not optional. EMS officers should be on all high acuity cases. Don't worry about getting them out of bed. Don't worry about getting them on the road. Getting an EMS officer on the road, getting a second ALS provider on the road to help you, and somebody who's getting sick in front of you is important. When people get sick in hospitals, we do not have one provider. ALS over ALS, bougie training, SOP is a guide. We have a new airway SOP that's out. Please read it. I think it helps give you guidance in the management of airway problems. We've talked a lot about the shift over the years in ALS airways from direct laryngoscopy to video laryngoscopy. Much more effective way of achieving endotracheal intubation in a highly reliable fashion. But what works better in terms of survival? King Air. So the prospective randomized data is that it works better in terms of survival. You're laughing at me because I said that live on the, yeah, a little bit, yeah, well, that's just data. The basic airway techniques are extremely effective. We know in a pediatric population, basic airway techniques are more effective than advanced airway techniques in the field in terms of managing an airway until a patient gets to the hospital. The misses in trying to use advanced airway techniques in pediatric patients amongst inexperienced providers, and for talking about pediatric patients, that means every single one of us, with maybe the exception of the anesthesiologist. But basically in pediatric airway, I mean, that's most of us. We're inexperienced. Basic airway techniques are more effective and safer for us in that situation.
Will taking airways be a BLS skill?
No, not in any time in the future. No. No, but they are an AEMT skill. Unfortunately, that's a level of provider we don't have in the state of Maryland yet, but hopefully soon. Only been in the rest of the country for a decade, right? CAD download required again. Electronic records have to be updated on a timely basis. Rich, you want to talk briefly about opioids abuse recovery? Already covered. All right. Other topics that I didn't get to that Sean?
Two events up here recently happened recently. One was a dwelling fire that resulted in a dumpster fire that resulted in some property damage. The other was a rescue that resulted in lifelong disability of a 22-year-old. We have an after-action review for the dumpster fire, but we don't have one for the rescue.
So our procedure with regard to case reviews is that they can be instigated at any level. So the providers on the scene can do a case review. If they want to escalate it and have more people involved, they can get the DOs can do that. They can reach out to medical directors. They can reach out to their shift commander. They can reach out to the EMS office for help doing it, and we encourage it. We had, for a period of time, in order to help encourage this process along, a minimum threshold for the number of case reviews that a district officer had to do each quarter, was it? Do you remember what that number was? 1 a quarter? Yeah. Yeah, that's not a terribly onerous bar to have to hit. I don't think we've enforced that aggressively. I'm assuming since Mike knew it so quickly, he's doing it.
Self-reporting.
Actually not, because there isn't any enforcement of it, and there was some feedback back from the crew. Why are we getting case reviews? What are we doing wrong?
Right. That's the atmosphere that's out there.
So
It's a case review. Oh, I'm getting in trouble now.
So I don't recall anybody getting in trouble out of a case review.
No.
That was initiated at that level. So when case reviews get initiated because we get feedback about a problem and we discover that in going through the Just Culture algorithm that it's not an issue of somebody honestly reporting mistake, but perhaps dishonest interpretation through there or egregious behavior. There have been times when we've kicked over into the disciplinary process. When case reviews are initiated based on somebody at the scene saying, we want to learn from this, call it something else if you don't like it, case review thing, call it whatever you want, and after action review, whatever. The idea of using your medical directors, using your district officers, using your resources that you have around, and perhaps even bringing in other people from outside, that idea is one that we want to promote. If you say I want more education, we want to promote that process.
I do have a question. I know we're going to be doing the T-Pod if you use those. It's a new piece of equipment. And I don't recall, was there a request to do case reviews if we use Raphael?
Not mandated.
Okay.
Not mandated.
Okay.
Not to my knowledge yet. Listen.
I review, we have a report that I run that we review certain medications that are given, and we do look at the rapid mills. We look at some, if it's a new med for a period of time, we'll look at it. We just do an internal chart review.
Now, what is the pressure sampling? So, like, I know personally I had a run of sugar that I had. We attempted for quite some time to get a medical director. Specifically, we wanted to have Dr. Bernius review it with us. Trying to get a medical director that was like pulling teeth.
Why?
I don't know. That's what I'm asking. We requested, I think Captain Torrey and I requested for about 5 weeks before we got a response back from Dr. Bitberg. We actually had a really good case review. But, I mean, again.
I don't know anybody, I mean, I'm not aware of, I'm not hearing responses waiting 5 weeks. Yeah.
And at that time, it's not even timely anymore.
No, it shouldn't be. But kick it up to the EMS office when that happens.
And also,
I'm not aware of it. Rich isn't aware of it. I'm not sure.
Well, what's the EMS captain, right? Okay, and that's supposed to be the leadership out there. They're saturated.
Okay.
I've heard from some of the more senior medical directors around the time that it takes to do the case review to make sure that everyone's learning from those. So I know Dave, I think it's April 18th, is coming up with this forum that we're going to start doing pretty frequent reviews of it. So those case reviews that happen, that you guys call for that happen, we're going to make those more widely available in this forum, for example, videotape. So perhaps we can all begin to learn from those case reviews. I know it doesn't address the timeliness that you're saying, and I agree with Dr. Pollak. You know, we want to be available and just keep pushing for that. But also just for everyone else, the case reviews. Hopefully we're going to start having some broader learning opportunities from those case reviews. The first one to take away.
Beth?
I attended an EMS conference recently in DC and was talking to paramedics from all over the world. And one of the things that really impressed me that I heard from one person was that in their jurisdiction, for every single cardiac arrest, there's a code staff reviewer that looks at the data and reports back to the crew within 24 hours.
We'd love to get code stat uploads for every one of the cardiac arrests. We're having trouble with that.
I've taken the training with the control twice, and I've asked if I can annotate just my codes or my company's codes, and I can't get access to the software. I've had the training twice, and I'm really interested in doing it. I don't think people's ratios are as good as they think they are.
Well, we've actually started to download in bulk the code stat information that we have from around the county. I can tell you that the real limitation is the number of cases where code stat gets uploaded, not that it gets annotated. So we've started to analyze it in bulk, and Sean's been working diligently. You want to give a 2-second update on where we are with that?
In brief, there's a lot of work within Hopkins. There's a young researcher who's been doing a lot with debriefing every code that happens within Hopkins Hospital, and that has required a certain amount of software to create a visual display of data that's more readily available to providers outside of what's housed within Lake Hospital. So what we've done successfully is merged CARES data and all LifePack data. We did a pilot for a month, and it worked really well. We were able to link those files that aren't connected naturally. We've been able to link those. So now we have 6 months worth of data that we're going through as well and creating some measures or a visual display of data similar to the high performance CPR data that is advocated for by HA. Data that we should all have, including providers after the rest. So we're actively working on that methodology, bring that together and to share with providers. First, we're at the leadership level, figuring out how are we going to make this sustainable. It can't just be a couple of people. Yeah, so I'm happy to talk to you afterwards.
Okay, and I'm happy to help with the innovation if you need.
Rich, how can we allow individual companies or DOs to get the data to review with their crews?
DOs have the ability through logging on to Citrix to be able to do it. It's a licensure issue of how many we have with that, so I believe we have 4 licenses.
But
so
for
four DOs can be logged on at any one time.
But for example, at Station 50, they could just reach out to MS5 who could get them the information to download, and then you could annotate the calls from your station.
Yep.
So just ask.
Rich,
Yeah.
can there be some updated training on that?
Working on that, it's May. May is what we're looking at with physio right now.
No, I'm saying if you want to look at.
But
Physio.
The good thing actually with Code Stack 9,
sure, that's
so years ago, and exactly what Beth is talking about, when it was Code Stack 7 and 8, you actually had to go in and you had to mark everything. Upgrade Code Stack 9, which is on there, and it's very little annotation that's actually required. It's just a matter of going in. If it was transmitted in, to be able to print it out and give the responses back. So it's much easier than what it was. So I do have physio coming in. It looks like the May, June time frame.
It's great. Can I come?
Thank you. We're at 9 o'clock. We'll let it. Thank you.